Katie, wave to me if you can. And I'm going to talk about PERC access, access for percutaneous nephrolithotomy. Now, why am I promoting PCNL and not ureterorhinoscopy? And the reason is that flexible ureteroscopy is very expensive. Your scope has got a limited life and it breaks your heart when you break one and you have to go back to starting again. It's common to need a JJ stent after flexible ureteroscopy if you're treating a stone of more than a centimeter. And also, you may need more than one session if the stone is bigger than 1 centimeter. Now, the ability to get a patient back to remove the stent may be interfered with. The patient may run out of money, they may not understand the need. And if you leave a stent behind, they can present years later with a dead kidney and be much worse off. Now, I've been involved in training in PCNL or NLPC, if you are French, in Africa since 2014. And I started in Gambia with, and in Senegal. That was my first trip to both those countries. And I met up with Lamine Niang, who has been a wonderful advocate of PCNL since that time. Then if you look at my list of places where I've taught, Bulawayo, Benin, Ethiopia, Harare, Cape Town, Cameroon, Ghana, Egypt, Zambia, Rwanda. But unfortunately, during the last year, no more places to visit because of the COVID restrictions. But the excitement coming on with remote mentoring using clever goggles to help. The adaptations I've made, I've gone from 100% prone to being 100% supine. And the other is that I've had to learn to perform the procedure using ultrasound alone, because in some countries there just hasn't been access to a C-arm. So what's the minimal kit that we need? You can read the list here. An operating table compatible with X-ray. And if you don't have an operating table that is useful with X-ray, then you can lash a trolley to the end of the table and bring the patient down over the trolley so you can shoot the X-ray through that. You need a C-arm, and also it's ideal if you have ultrasound, and I'll explain why later. But you can manage without a C-arm with increasing skill with the ultrasound. We need a cystoscope to put up a retrograde catheter. And if the prostate is very big, we might need a flexible cystoscope. Expensive, but very useful, and actually very useful in the kidney for negotiating around certain bends. I like to have methylene blue so that I can tell whether I've made a puncture into the collecting system. If there's a little blood staining, it makes it obvious. We need a puncture needle, a needle with a stilette and a cannula, guide wires to go through it, dilators to go over the guide wire, and an Amplatz sheath to work down to get the stone out. A nephroscope to view, and we need a fragmentation device. Now, some of the stones in Africa are extremely hard and resistant to fragmentation, but I have not found a stone yet which I haven't been able to fragment at all. We need retrieval devices, forceps, for example, or baskets, perhaps. We need saline for irrigation, and we need a mentor for the first cases. And the question is how many before you feel comfortable. And I think ideally you want to have been mentored through about 20 cases, but this may not be possible. And sorry, I'm just trying to get my next slide for some reason. A technical hitch here, guys. it stopped letting me go forwards. Excuse me. Katie, any advice?
I'm not sure. Have you tried pushing with the arrow key?
I have indeed been doing that, and it was working, and then it stopped. Oh, look, here we are. So why have I gone to supine over prone? And the biggest reason is that anesthesia is safer with going supine. When you're prone, it is so much more difficult for your colleagues. It also makes the clearance of fragments easier. But otherwise, there's little difference to us, the urologists, but a massive difference, I feel, to the safety of our patients. So I strongly recommend that we go supine. Now, when we do a puncture going prone, we used to make the puncture relatively medial. My technique was to come in, as you can see here, relatively medially, and it was very important that I went for a posterior calyx. The posterior calyx was always medial to the anterior calyces. If you went for an anterior calyx, there was a good chance that you would fail to get into the rest of the collecting system, or at least it would be difficult. But when we come through prone, and I hope this will then move on. Sorry, this is being something of a nuisance. Next slide. It'll suddenly happen. So what I was going to show you with my next slide, when it eventually appears, is that when you come from the supine, you come in through by the tip of the 12th rib, and you're coming in very much more laterally. When you come in like that, it makes very little difference whether you come in through an anterior or a posterior calyx. Both lead onto the stone, and it frees you up with so much more freedom to get into the rest of the collecting system. Now, I'm still stuck on this slide, and I'm going to just try and, nope. I do apologize to everybody.
I wonder if it would help to try shutting down PowerPoint and then opening it up again, because it seems like maybe it's just.
And I've actually tried to hit escape to leave PowerPoint, and it won't let me.
Mm.
And my pointer isn't arriving. I'm so sorry.
Oh, you're okay. Maybe you can stop sharing and then try sharing, just stopping the sharing and then sharing again.
Yep. But I can't point to the stop sharing button.
Oh, your pointer's not working.
Yeah, because my pointer isn't working. Normally, if I hit escape, it would take me out of the PowerPoint.
Do you see? So you see the button that says stop sharing, and it just won't let you click it?
Yep. And I can't hit that, unfortunately.
Maybe let me see if I can stop your share.
Try. And then I'll reboot.
Okay, I just stopped it. Maybe that'll help.
Yep. Now, okay, I'm on to the next slide. Can you see this?
Now you have to share it again. I just stopped sharing.
Okay, can you share me?
Unfortunately, you have to share yourself. You just click the green button that says share screen.
Okay, I'm now going, I've now got my pointer back. Can you see the slides?
We can't. You have to click the button that says share screen first.
Right. Excuse me 1 second.
You're
I
fine.
do apologize. I've now got my button back. I've hit share screen and it's probably.
Oh, now we can see something.
Yes.
We're seeing the paint app, I think, or what is this?
Right. Let me just play again. So here's the slide to show that when we're in the supine position and we're coming in from more laterally, posterolaterally, it doesn't matter whether we hit the collecting system through a posterior or an anterior calyx. Preoperatively, do we have any reason to suspect a coagulopathy? If there is, for example, the patient's had liver disease, or then check the clotting. Make sure the patient is not on anticoagulants. And the other very important thing is the urine sterile? Do not operate on a patient with infected urine. And if they're continually infected, then have them on antibiotics for 7 days leading up to the surgery. Step 1, we place a ureteric catheter about 15 centimeters up the ureter. If it doesn't go in easily, then there's something going on, perhaps a ureteric stone that you weren't aware of, and think about doing a ureteroscopy. Remember to cover the patient with antibiotics, a broad spectrum antibiotic. I use gentamicin, cheap and very effective. We place the patient in the for a supine PCNL with a rolled cloth or some sort of sponge underneath the buttock and another one underneath the shoulder to just elevate the side enough so you can get access to the tip of the 12th rib. And we're usually going to go just under the rib. Sometimes we go just over. We then clean and drape, thinking about how we're going to collect the irrigant. Now, this slide, drawn by me, not by my 4-year-old grandchild, shows the patient as we do it in the frog leg position. So we don't have to put the patient up into stirrups. We just do a very simple procedure with the towel over the patient, and we don't have the legs up for the whole of the procedure. Some people do. And this just makes it quicker, easier, and cheaper. And then the next thing we do is we position ourselves with the X-ray screen opposite on the other side of the table, the C-arm coming in from the line of the puncture. And so what I do is I lay my needle over the patient, and I'm looking on X-ray for the stone. So my perk needle, my access needle, is lying, it's that red line, and it's lying on top of the patient. My C-arm comes in, and I try to bring the C-arm in the same line as my puncture. And then I know roughly in what direction I'm going to go. And by having the C-arm in the line of the puncture, it makes it much more straightforward when it comes to understanding the depth. So I orient the image so it's logical to me, and left is left and right is right. I have the video stack on the other side of the patient, the ultrasound on my side, and the irrigant so that I can see when it's not flowing. If at any stage the irrigant stops flowing or you run out of irrigant, you lose your view. And what you don't want to do is to pull out your scope, just looking for the way to the rest of the system. Before you inject any contrast into the system, get an image stored, if you can, on your X-ray device, on your screen, so that you can remind yourself what it looks like. And do not over-distend the pelvic halocele system, or you get extravasation, and then life becomes very difficult. It only allows me a few. Here we are. So now I'm going to show you how we use the C-arm to swing it over laterally in order to see whether we're too deep or too superficial. So imagine that the stone you see there just underneath the C-arm, you can see a black point, which is the needle going straight for the stone. Red is too superficial, and green is too deep. When I take my X-ray from above, I cannot tell the difference. And every image would be like it is on the left, with the needle going straight towards the stone. But when I move my C-arm over to the right, it could be the left, but I'm going to move it to the right on this occasion, you would see the picture on the left, that the needle would seem to be pointing too far to the left if it is superficial, too far to the right if it is deep. What you do is you imagine how it would look if you were looking from where the head of the C-arm is coming. That tells you the depth. Do not change left or right. You've got that absolutely right. Just change your pitch, whether you're going to go deeper or more superficial. And then, so what I do is I return the C-arm to the vertical position, bring back my needle sufficiently so that I can make a puncture in the right plane, deeper or more superficial, until I'm on the target, on the stone or the calyx that I'm trying to find. So here we see on the model, and I'm going to show you a video of this in a minute, I'm aiming for the stone. When I move the C-arm over to the right, I can see that the needle has moved way to the right. That means I'm far too deep. I come back a lot, and then I approach the system, coming more in the right plane. Now, if I may, I'm going to show you a video of me doing a puncture on a model. So I hope this will work. I'm going to show you how to use X-ray to target a stone. We're going to use the model of a real stone inside some sponge, a real X-ray machine. And as in real life, we would set up the image quite clearly. We would have our C-arm, the axis of the C-arm, as close as possible to the line of puncture. The first thing I want to do is orient.
It's a little bit hard to hear you, Dr. Watson.
To take a flash, you can see the stone in the middle of the view there. I place my needle over my proposed line of puncture, take a flash, and you can see that is now
share the video.
White cells coming in from where I stand. Let's make life
We are not
easier.
seeing the video. We are not seeing the video.
So that I'm coming in from the right direction. Are you seeing the video now? So now I'm oriented.
We can see
No.
your face now, but we can't see the video you're trying to share.
We can't see the video.
I'm so sorry.
Share the video.
You just seeing me?
Mm-hmm.
Yes.
Well, and we can see your
I
power.
was so,
We just see you.
how do I share the video?
Let me stop your sharing again, and then you can share again.
Yes, I'm sorry about this.
Oh, it's okay. Okay, I just stopped your screen
got it.
sharing. So why don't you push screen share screen again?
Right? Can you see this now?
Now push share screen again on the bottom.
It's disappeared. I'll escape. I'm so sorry.
Okay.
So,
Are you back on the Zoom app?
yes, I am. Share screen.
Mhm.
Can you see this?
Yes.
Yes, yes.
I'll show you how to use X-ray to hit. If anything, I would think I might miss it ever so slightly to the right, which is deep. I'm just going to bring this back a bit. I'm so sorry.
Oh, it's fine.
I'm going to show you how to use X-ray to target a stone. We're going to use the model of a real stone inside some sponge. We've got a real X-ray machine. And as in real life, we would set up the image in front of us quite clearly, and we would have our C-arm with the axis of the C-arm as close as possible to the line of puncture. The first thing I want to do is orientate myself. So I've got the radiographers to take a flash, and you can see the stone in the middle of the view there. I place my needle over my proposed line of puncture, take a flash, and you can see that is now coming in from the right side instead of coming in from where I stand. Let's make life easier and move that image around so that I'm coming in from the right direction. So now I'm oriented, left is left and right is right. I'm going to start again. We'll place our needle roughly over the line of the stone, and then I make a guess of how deep I'm going to go. So I advance my needle some way towards the target. And as I approach the target, before I puncture too deeply, I want to know whether my depth is right. I'm absolutely right in that AP plane. What about depth? So I'm going to move my C-arm, in this case, over to the right side. So imagine you're looking from that right side. What we see on the image there, if you look at some flash, is that that needle has moved to the left. Now, if that was my target, and this was my needle, if I look from above, I'm going to see them in line. I can't tell if I'm deep or superficial or on target. When I move to the side, if you then see the needle has moved to the left, it means that in fact you are superficial. So I'm going to go in a bit deeper, back to the AP direction. I'll just go in a little bit deeper this time. Advancing my needle. And before I've got completely onto the stone, let's repeat. Move the C-arm over. And this time, you can see that that needle is in fact, I'm pretty much on line to hit. If anything, I would think I might miss it ever so slightly to the right, which is deep. Let's come back. So we'll go ever so slightly superficial as I advance forwards. So if I move my C-arm over now, forward to. So here we are looking at the stone, and if I move over laterally, I'm still on target. If I move it the other way, just to corroborate, I'm on target. If anything, looking from this side, I'm going to miss ever so slightly to the left, and from this side, that would mean deep. Let's just go over the other way. From this side, you'd hardly think that looks exactly on target. What I'll do is advance it. And I can feel myself hit the stone. I'm on the target. So that's the principle of using the X-ray from above and then going laterally, rotating sideways to get the depth. You can tilt the C-arm in the other direction. I'll just show you what happens there. So let's purposefully I'll probe in the wrong direction. If I look on the side, that's way too superficial. Now let's try and move the C-arm over, you'll see what difference that makes. You see the difference with the distance between the stone and the skewer. Now, my skewer seems to have moved forwards. That means I'm superficial. So if I breathe a little bit deeper, not changing left to right, but only changing difference in the time to time. Right, I'm just going to move back and go to my slides again. Excuse my difficulties. So let's talk about ultrasound. Now, if you've got ultrasound, can you hear me? But fingers up if you can.
We can't see your slides.
Yeah.
What if I
Neither.
what if I stop your
Go
screen
back.
sharing again, and then you screen share your slides?
Thank you. Sorry about this, everybody.
Oh, it's okay.
Okay, we've got it.
Yeah,
Can you hear me?
we can hear you.
So,
and now
and you
share your screen again so we can see the slides.
Right.
Yeah, screen.
So with ultrasound, we've got the, I like to use ultrasound on every case. It shows you where not to puncture. You will see the liver, you will see the spleen if it's going to be in the way, or bowel. If you see it, don't go through it. You're going to use less radiation. You've got a continuous image with 3D all the time during the puncture. And it comes into its own.
Dr. Watson, did you have slides you wanted to show while you're talking?
I do beg your pardon. I thought I was showing slides.
No.
Do you see this one?
Share screen again.
Okay. We'll do it. We will try. This is a pain.
It's hard to always switch between, you know?
It really is. And let's, now I want my slides to come back. Please, slides, come back.
Okay.
Click the share content, okay?
So I am play. Can you see this?
Yes, yeah, we can see.
Good. So it comes into its own when you've got a completely obstructing ureteric stone and you can't get any contrast past the stone. Then ultrasound becomes absolutely essential. The limitation is with the very fat patient, and you have less of those in Africa. And so here is a typical image. You can see dilated calyces as black. You can see a white stone on the left there. You can see the liver, or is it the spleen, poking its way from above, and there is bowel to the right. It shows you the line of access. And if you have this particular device, the Hitachi Arietta, it comes with a cutout in the center of the probe so that you can place a needle guide and you can direct your needle very accurately in the line that you want and hit the collecting system. I find that very easy. And you can see here the stone showing up as a bright shadow. I'm going to make a puncture into a mid-pole calyx, and then I was able to get that stone. And here we see the setup, and then we see the blue dye coming out of the needle after a successful puncture. Then we put a guide wire in, and we hope to get the guide wire down the ureter. Now, if I may, I'm now going to show you some videos, and I do hope this is going to work again. So the first video I'm going to show is of my colleague, and he and I work using the same system, and so I hope that this is now going to work. Can you see the video?
Yes.
Yes.
So, and you can hear me, I hope. So what you're seeing is the system with the legs frog-legged so that you can do this without getting the legs up, and just one simple towel placed over the patient as we insert the ureteric catheter, in this case going up the left ureter. And so we don't put the legs up into lithotomy. We do put a catheter in and just to help drain the bladder during the procedure. And then we've got a catheter going up to the kidney, ready for the puncture. And what we're going to show you here is a puncture using X-ray. And the first thing is positioning the patient, pull them slightly towards the edge of the bed on the side that you're going to operate. Then we raise the the patient up and put some support underneath the buttocks and underneath the shoulder. And he's just going to draw where is the 12th rib and where is the pelvic crest. And all our patients have beautiful tattoos on them before their surgery. So that is the tip of the 12th rib. And that is the posterior axillary line. This is my Arietta ultrasound. And this is Simon Mackey doing the procedure. And he's just going to use the ultrasound so that he knows how to avoid the spleen and the bowel.
So can I just show? So here is the stone, this white, this green messenger, that's the stone, or it could be the ureteric catheter, but I think that's the stone. And the black is the dilated calyces.
Most importantly, there's nothing in the way if we're using this trajectory. So marking here, my trajectory will be just through there in the squidgy bit.
Around here. So this is colon. But this is muscle, perirenal fat. So it's safe to come through all this. But that is not safe there. That's colon. A shot rate would be quite good.
We're using an orthopedic drape called the beach chair drape. But any drape which collects the irrigant is ideal, not always possible for us with limited resources, but it does prevent getting water on the floor and over electrics. So we've got blue attached to the ureteric catheter, and he's going to use an X-ray technique. He's going to just have the X-ray back a little bit so it's going exactly AP through the patient.
So, towards me. So, stacks through that way. X-ray screens in. Flash there. X-ray. a little bit of rotation, and not quite, 5 degrees, just on the image. Screen.
Yep. I think it was where we thought it was done.
So the stone is actually in the renal pelvis.
That's between two creams.
Good. Okay. So first bit, guesstimation.
So he's introducing his probe almost horizontally in this position. And you can see the needle coming in. So we know we're right on the AP, but are we right for the depth?
Okay, so what I want you to do now,
We see the needle move. 1 second.
So we know we're at least in the kidney because the needle is moving with respiration.
okay, angle 45 degrees. Keep going, keep going, keep going, keep going. Flash. Angle a bit less. Stop. Flash. Okay. So we're not too bad.
So he's actually managed to come almost exactly in the right plane. It's not too deep or too superficial.
Okay. Over the top, please.
So he's going to make the advance now with the C-arm overhead as he goes for that calyx.
Stop screening. Angle 45 again. Stop. Flash.
So he looks exactly on target, and
The other way. Flash. Okay, looks like we're on target. Over the top, please.
so we'd all agree that's exactly on line.
Vertical, please. Stop. Screen.
And it's useful to use the C-arm continuously for that final puncture. And you can sometimes feel a little give as you enter the collecting system,
Wire, please.
and then you see the blue coming out of the catheter. When you put your wire down, the ideal is if the wire goes down the ureter, because that gives you complete security. Now I'm going to show you a little bit of the dilatation using metal dilators. So these metal dilators are called the Alkan dilators, and after Peter Alkan, and it starts with a central rod which has got a collar on it halfway through. When you pass the central dilator, you make sure that you're always going in the direction of your puncture, and just with X-ray, see it going in the right plane.
Screen.
Making sure that you don't have a sudden give and poke your dilator through the other side of the kidney.
Screen.
So he's just going on to the calyx, and now he's through into the collecting system.
So she's got quite a mobile kidney. So I could feel the kidney pushing away from me, bouncing. What I did is I rotated and just kept firm pressure on. And then for the final bit through the cortex, I just gave it a little bit of an extra nudge.
Now these dilators are going to go on, and you just make sure that you hold on so that you don't advance the dilator too far.
Flash. 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 Flash.
So you saw him use a bit of extra contrast to know that he was in sufficiently. This is the Alcan sheath, the amplat sheath, I'm sorry, going over the dilators through which he'll work.
Flash. Rajesh, do you want to come round?
And
Go round the
I'm going to stop this video now, or do you, no, well, hold on. I think we'll just see that he is indeed in the system. I hope we will.
Can you see the other room? There. Yeah, you see? Yeah. Flash.
You just move out the way for the video. Great. Sorry. We need.
Flash. Okay. So if you look there,
Still short.
it's about 2 centimeters short.
Just here.
Very supple. But I'm actually in the collecting system because the dilators have gone loose. But I'm just going to advance a little bit further. Well,
Can you now show how far in you are on that system?
If you were to advance your implants beyond your
You've got the danger of taking a forward.
Flash.
And that's it. I'm going to just leave this video now and show you a case where we use where we use ultrasound for the puncture. So I hope that this is going to now work. Can you hear me? Can you see this? And can you hear me?
Yes. We can hear you.
Can you see the video?
The video is not on.
Okay, I need to resume. Sorry, I'll just stop and escape. New share. Can you see this one?
Yes.
Good. So the same frog leg position in order to put in the ureteric catheter.
Mhm.
And again, making sure that we don't, we're not going to take too long as we do the procedure.
The same as we saw before.
Ureteric catheter going up the left ureter, urethral catheter will then go in. And then we'll position them as we did before. Now this patient, instead of having just a solitary stone in the renal pelvis, has got a staghorn obstructing her system, making life a lot more difficult. And I'm also going to show you how to put in a safety guide wire outside the amplat sheath. So the same positioning with a roll underneath the buttock and underneath the shoulder tip.
Or do you want to cart away?
12th rib there. And that's showing you the posterior axillary line and the 11th rib.
So 12th rib is there, 11th rib is there.
The same drape. We're going to have the X-ray there, but we're going to use ultrasound for the puncture.
Type it all down. So we've got a little bit more AP. Go a little bit north, in case we see stone up there. Right. There we go.
So the stone is radiolucent.
So save that.
This lady has MS and is bedbound, very unfit.
Okay, so that's the kidney appearing now, and you can see that's pretty much invisible. I think I can see some tiny bits, Simon. I can see, yeah, we'll see that. Start again. Start again.
So this is the Arietta probe that I showed you earlier. And we're going to put in the needle guide, which fits over the inset into the head of this ultrasound probe. And we then choose whether we're going to be 0 degrees, 30 degrees, or 15 degrees.
And we've got the 3 points, 30 degrees, 15 degrees, 0 degrees. The needle will fit through 15 degrees. So you can see on the kidney, you can see great collections of stone there. And as I fill it, something of a collection.
So there's very little room around the stone for the contrast to fill, but you can see the stone very clearly.
So I've decided where I'm making my puncture.
You make a puncture in the skin before you insert your needle.
Very much more anterior to where I would do it if I didn't have ultrasound. Choose my track. Make sure I've gone through the hole that I've made. So it's just beginning to hit the there.
And if you twiddle your needle enough, you can see the needle.
That again.
It looks like
I'll be close, if I'm not in.
And then we've hit the target. Now the difficulty here is that it's very difficult to get the guide wire down the ureter. This is a sensor guide wire, which has just a hydrophilic 5 centimeters at the tip.
As far as I can get it in today. It might move in.
So we would like it if that guide wire went down the ureter, but it will not.
Plastic dilator. So we're going to use serial plastic dilator. So the first thing we do.
So these are the Amplatz dilators, which you may have seen, and these can be, they're designed to be used once, but I'm sure you will be using them many times over.
Yes.
And make sure that you dilate in the line of the guide wire.
There it comes there. So you see the guide wire in there.
So don't dilate too far. That's perfect. Once I've dilated up to 10 French, I can put in my central 8 catheter. And I'm going to show you how we can put in a safety guide wire.
Okay. Now we put in this little fella.
So over the top of that blue comes a little cannula that fits snugly over it. I advance that over the central 8 until I'm in the collecting system.
Now then, if I come out, we're leaving the blue guide wire.
So out comes the plastic dilator leaving that outer sheath behind and leaving the guide wire behind. So that's what I'm doing here.
So what I'm doing is I'm leaving the guide wire behind. I'm taking out the central blue. Good. Now I'm in the second guide wire.
So in will go a second guide wire.
Did that on purpose. Yeah. You can now see that's definitely an upper pole. That's that. Oh yeah. Okay, that's all it's on. Going into that. Now I'm coming out with my hold the 2 wires together.
You come out with your outer sheath, leaving the 2 guide wires, and then you dilate over just one of those guide wires.
And now we hold one, we put the other one inside the drape.
What do it?
One inside the drape, and the other one we dilate over.
Okay. So the dilator will.
And then I continue the dilatation, and that will give you 1 guide wire outside your amplet sheath and 1 guide wire within it.
Unfortunately, I'm the little one. If I'd known which was the right one, I would have chosen the one in the other one. Right.
So we continue the dilatation. I'd like to stop this now and take questions, if that's all right. So I'm just going to come out of the video and come onto come onto my image, if I can do that, and answer questions. I would like to apologize. Can you hear me?
Yeah, we can hear you. I received our
And
first
can
question
you-
over email. There's 2 questions. The first is, what are multiple access puncture indications?
Right. Well, obviously, ideally, we're going to make our first puncture. We're going to make the puncture lead to the stone, and that comes with experience. When you've got a staghorn calculus, or you've got multiple calculi, you may need more than 1 puncture. If you've got a flexible cystoscope, it would allow you to move around the kidney more. If you're very rich and you have a flexible ureteroscope, then you can do a combined procedure, combining flexible ureteroscopy with percutaneous surgery. But I would very rarely do 3 punctures and almost never 4 punctures in one procedure. And after you've made a puncture, you re-puncture onto the stone. And in a staghorn calculus, you would be using, or you could avoid using any contrast, because the stone is the contrast. That way, you know you're going for stone, not for residual contrast in the collecting system. I hope that's clear.
Thank you. The second question that I received is, does the supine position avoid multiple punctures when the stones are in different calyx?
No, it's very similar. It's going to be the same whether you come prone or supine. But as I said, supine does allow you to combine it. So flexible cystoscopy allows you to get into other calyces. Coming in laterally allows a lot of latitude in terms of accessing different calyces, but occasionally you have to make that second puncture to get the rest of the stone. But as I say, I would limit yourself to 2 or 3. The starting point first of all, remembering the model that we used, work on a phantom and get your team used to doing a puncture as you saw there with a stone and a sponge, or using a metal nut middle of a watermelon. These with X-ray, you move on to having conquered an exact hit on the stone. You can move to the patient, and we've reached the age now where we've got the ability to do remote mentoring, and so there's a site called intersurgeon.org on which you can register, intersurgeon.org. And with that, you can join Help Lightning and Vuzix Glasses, and various charities that they're helping us to promote global surgery, which would allow you to then connect with someone like me or with Lamin Yang, who could then help you through your early cases. And I'm going to include Gilles Natchagande in this because he is now becoming a great expert at percutaneous surgery. Can you hear me?
Yes.
Good.
We just got another question to the chat. It says, have you ever had severe calyxial fibrosis where the dilators do not want to enter the calyral space? What is next? More rigid Lindquist wire or using more force?
The trouble with the Lundquist wire is that it is, once you kink it, you lose your track. So I used to use Lundquist wires a lot. I've moved now to the sensor wire as being something that I can use many times over. And by just always following the line of your guide wire, you can get in most cases. Now, if you are making your track to 32 French or 30 French, you're going to have more difficulty with the dilatation. And I would strongly recommend that you keep to something more like a 24 French track. That's plenty in order to do the procedure. So you saw us in that video doing a mini PCNL in the first case with an 18 Sharia amplats, and in the second case a standard with a 24 Sharia. With 24 Sharia, you rarely have trouble with the necks of the calyces. With 18, almost never. I've always managed to get through eventually. I think one of the times when it's most difficult is somebody has got a lot of fibrosis around the kidney, as with previous surgery, and especially if there's been a lot of extravasation. And there are times when dilatation can be very forceful. And what you've got to do when using force is to be very careful that you don't suddenly plunge your dilators in too far and perforate the collecting system medially.
Thanks. We just got another question. It says, supine upper pole punction is sometimes very difficult. How to deal with it?
Right, because I think that whether you're prone or supine, the upper pole is the more difficult place to puncture. And the difficulty is generally because your movement from, it becomes more, you're coming through more tissue, number one, and you are at an angle to your C-arm. So what I do is I make sure that my needle and my C-arm are in line, even if I'm having to bring them up from up near the head. As I was showing you in one of those cartoons earlier, one of my drawings, I line up the C-arm so it's coming in the line of my needle puncture. And that way, you keep the geometry very simple and triangulation becomes very simple. You move to the side and you know your depth. You just, with practice, become quite capable of doing precise punctures into a precise part of the kidney. And with practice, it just becomes easier. But please start with very simple stones. So a stone in the collecting system. Get used to doing punctures. If you can get used to putting in your own nephrostomies in patients who need nephrostomy drainage, this is a great way of learning before you come into the operating theatre to do your percutaneous surgery. And personally, I think ultrasound is a great way of starting to learn, but you do need to conquer both skills, ultrasound puncture and X-ray puncture. And I hope this little talk has just given you a flavor of and a bit of confidence in thinking, hey, I can do that. That is not difficult. That is straightforward and logical.
Are there any other questions?
I wonder if we could open up Lamine and ask him to make a few comments.
No, today I'm learning today. It was a very nice talk, I think. And as you know, the puncture is challenging in PCNL. If you do a puncture, I think 8% of the job is done. And
Yes,
what we have to learn,
completely agree.
What we have to learn is the puncture, I think.
Yeah,
and
I agree.
Triangulation is the best way for beginners. But the monoplan without moving the C-arm, I think, if you have some cases, it's sometimes very, very quick. If you do the puncture without moving the C-arm in monoplan.
So we're using using the way where you are looking for the kidney to move with your needle, you just keep changing your direction until you see the calyces move.
Moving, yes.
Yep.
I think sometimes it go quick.
Yes.
You can save some sometimes.
But I think also that with experience, it all goes quicker and quicker. So your operating time, everything becomes more familiar. Just get the cases under your belt.
Yeah, and combine ultrasound and C-arm is very nice, I think.
Yes, I do agree.
We just got another question in the chat. This person says, in case of colon transposition, should we always favor the prone position?
Well, what I would say is where with the colon, ultrasound is really good at showing you where the colon is, and so please use ultrasound, and it really helps you in knowing where your window is. And life is full of surprises. Something it's not always easy to work out where the colon is from the CT, but with ultrasound it's very straightforward. And basically, you don't see through the colon; you just see there's no window there. So ultrasound, and you find your window.
I see sometimes you use a safety guide wire now.
I was showing the safety guide wire because it's a great way to start. Get a safety guide wire in, and you've got that as backup. When you've done a few cases, and Lamine, you've done I would think a couple of thousand cases, it's no longer necessary. But when you start out, be as secure as possible, and the safety guide wire is very helpful. but you want it outside of the sheath. And so I was purposefully showing you how you can do that using those Amplatz plastic dilators.
Yeah. If my puncture is difficult, I do it. But if
Good.
it's a very nice puncture, it's not very difficult. I know even I lose the wire, I can puncture. I don't
Yes.
use it.
Yes, I agree. I agree entirely. I find that I don't need a safety guide wire now, but I'm very long in the tooth. But I would strongly recommend a safety guide wire for somebody who's just setting out.
Yes.
And remember, try to get the guide wire down the ureter. The advantage of having it outside the sheath is you can move around very easily within the kidney.
Yeah. Which is the best guide wire? Sensor or Terimo?
Well, I like to use the sensor, and the real reason is because then I save that sensor wire for Africa, and if the pure hydrophilic guide wires they become unusable after a few goes, but the sensor wire will last many cases. So while we have an uneven world with unfair distribution of surgical equipment, I'm busy collecting as many of these as possible to send out to Africa. That's something I'm very active in at the moment.
Yes, we need it a lot, yeah.
I have many for you, Lamine, and for anybody starting out.
Coronavirus have to stop, and we see you again here. We miss you a lot.
I would love to join you, Lamine. And we need to spread. I think PCNL is such an important technique, and we need to have a movement going where we can spread this throughout Africa.
Yeah.
And I will personally be so happy to start traveling through Africa again soon.
I'm really agree with you. It's difficult to do flexible here. It's very expensive, and the way is PCNL.
We have
D'accord, mon ami.
We have another question in the chat. They say this might not be the scope of the talk, but what preferred fragmentation and evacuation devices for large stone burden?
Right, because that's a great question. And it comes down to money. So we have, personally, I have got a device called the shock pulse. And what is supposed to be even more effective is the trilogy system, which is being distributed. And basically, the problem is that some stones are extremely hard. Now, cheap and affordable is a standard ballistic lithoclast, which will smash the stone up. Ultrasound has got the advantage that it can suck out the fragments, but it's very slow. And a combined ultrasound and ballistic is quite expensive and quite complex, but very good. I think that it depends on your finances, because some of the more expensive systems cost in the region of $50,000, whereas you can pick up an Indian stone fragmenting device for $2,000, and the EMS battery operated fragmenting device, the Stonebreaker, for about $3,000. So is it really worth all that extra money to have a device which will break up the really hard stone? And I think that what we need to do is to have a group of us who sort out the question of money over device capabilities. Is it really worthwhile spending all this money for something which is just a little bit more effective? Has anybody in the audience had experience of different devices?
Yes, I have some. We have in the Indian one
Yes.
who broke all stones. I never see a stone we can't broke with the Indian. But in
Well,
other
that's great
hospital,
news.
in other hospital, in military hospital, they have now shock
Shock
pulse.
pulse.
Yeah, it's very nice.
It's very nice. I
But
have shock
but
pulse.
it's very expensive. Yeah, we have
But
it in
very
one
expensive.
hospital, in military hospital. It's very nice.
Good.
Because he sucks
No.
the stone. Because the Indian,
Yes.
you sometimes it's bleeding, but in the shock pulse, you can
You
have
get
a
less
nice-
bleeding.
Yeah, that's the and no bleeding.
And in the in terms of removing the fragments, I use forceps. If I'm using a very tiny track, I have to use a much smaller device like a basket for the mini perks. But they are making these very nice stone grasping devices. Cook makes some very nice stone retrieval devices, which are designed for percutaneous surgery. And I will be getting my hands on a few of these to distribute. Get in touch with me if you are interested in exploring this.
Yes.
And get in touch with me via pausa.
Oh, just one more question. Someone says, have you got an opinion on Store's Min perk system?
The Stort's mini perk, and I love it. So it's just a case of how big a stone burden you've got. So you're going to be limited in what you're going to use down it to break the stone, and I'm pretty much using a laser when I use the Stort's Mini, and with the Ultra Mini, it has to be a laser. So do you have a laser? And then you use little baskets to take out the pieces. So great for a stone of up to 2 centimeters, solitary stone. Otherwise, I'm doing a standard perk with a 24 Sharia sheath. And the advantage of using a small scope is you get less bleeding. And it really is tremendous difference from the track. So small tracks, less bleeding, but much more meticulous time spent taking the fragments out because you have to break them up so much smaller to get them down your sheath. So the mini Stort's sheath is something like 16 Sharia. But I love the system and I love the scope.
But if you use a mini perk, you need a laser. And
yes, I'm afraid you do.
And a powerful laser, not a laser 20 watt, or you need a powerful laser to go very fast.
Yes, but I'm
and it's difficult in Africa
with a stone of which is small, you can get away with a 20 watt laser. It will still be very useful. It's only when this, but I agree that that otherwise you need a powerful laser, and then you're talking about big money.
Yes.
So some lasers go up to 120 watts and will clear the stone very quickly. Never use these high powers anywhere near the ureter, though, will you?
Well, if those are all the questions, I just want to say thank you so much, Dr. Watson, for presenting, and thank you to PALSA for attending and getting this out there.
Thank you very much indeed for having me. I apologize for difficulties with my my technology giving me troubles with this. I'll do better again next year.
It looks like we do have one last question. They say stenting a procedure after a large stone procedure / routine.
Right. I try to use stents as little as possible. But if I've done a large stone, I will leave a nephrostomy, usually for 24 hours. There are the times when if I leave a nephrostomy, I don't need to leave a stent. The only time I would strongly recommend stenting is if you puncture the system medially. You've dilated too far medially and you leak there. Because if you just leave a nephrostomy, the nephrostomy can fall out, and then you have to come back and put a JJ stent in. So I rarely stent after a percutaneous surgery. And the whole reason, the raison d'etre, is to try to avoid stents as much as possible. So just a nephrostomy if it's a complex case and in your early experience. But with greater experience, you can start to explore leaving them tube-free. And if there's infection, if the patient has got poor renal function, you have to drain. Thank you.
Hello.
Dr. Watson.
Yeah.
Hi, Professor Nwafor.
Yes. I think it's been a very wonderful session, hearing from the master directly. And we're learning from a lot of your experience. We are quite grateful to you, Dr. Braham, and then to IVUmed for anchoring this. And we look forward to continuous relationship in future. So I thank you all, and I thank our members for hooking on, and we hope that the next one will be better. Just keep checking your mails. You will see the details and dates for future programs. Thank you very much.
Thank you very much, sir.
Yeah, thank you. I hope you all enjoy the rest of your days, and for some of you, your evenings.
Thank you, Katie.
Yeah. Okay, thanks. Bye.
Yeah, bye. Bye.